So the topic that you asked me to speak about, Medicare Advantage, is really near and dear to me for a few reasons. One, it's a decision I had to make when I turned Medicare age. It's a decision I've seen family members come close to going the wrong way on, and I've kind of nudged them in a better way. And I've learned more and more that an awful lot of people don't even know what it is and don't realize what decision faces them, and they certainly don't understand how this is a direct frontal assault on Medicare and ergo on anything that we want to build on to make Medicare for all. So I consider the campaign against Medicare Advantage, or advocating us all about Medicare Advantage, as part and parcel of how do we protect traditional Medicare so that we have a public health system that we really want to, that we really can use as the basis of what we build, with some changes, of course. So the run of show is we'll talk a bit about what Medicare Advantage is. We'll unpack that. We'll explain some of the challenges with it. It'll all be sort of data-based. There's some things in here that I'll mention that I'm sure many of you will know. And if I'm saying something that you know, what I'd recommend is kind of pay attention to the way that I'm framing and discussing it. I've given that quite a bit of thought. And then at the end, there will be sort of summarize it with how you can use this information. And then lastly, there's the time of tonight for this session is really important, because there's a very specific call to action that I'm going to ask you all to do in the next few days, which if we put that off for a week would not be something we could do. So let me set this up. There we go. I think you can see my slides now, right?
Correct.
Yes,
Yep.
very well.
Okay, good. Okay, so that's kind of what we're gonna talk about. Just to sort of set baseline, perhaps, maybe in part for the students or those who don't know, traditional Medicare is an incredibly efficient, simple system. All sorts of complexities that I'm not going to go into, but in basic structure is really simple, and as such, it operates with a 2% overhead, more or less. It's just set up that we pay our taxes, we get our Medicare card, and then Medicare essentially pays doctors and hospitals and others on our behalf. There's, of course, more complexity than that, but that's the core structure of traditional Medicare with a 2% overhead, more or less. Medicare Advantage is completely different. Instead of Medicare paying doctors and hospitals on behalf of all of us, instead, it pays all the commercial insurance companies, or many commercial insurance companies. So right off the top, it's more complicated. And then they each have to have their own contracts with doctors and hospitals and such. So again, more complicated. And just to add one more level of complexity, they have, we like you to go to this doctor and not that doctor, go to this hospital. So they have to manage all that complexity. They have to deal with it, and we have to deal with it. If you want to improve quality, the number one rule is simplify. Simplify. That's what Deming taught us, who like to work on quality. So it's fundamentally complicated, and that means that they also have all the managed care tools that we don't like, that get in the way of healthcare. Prior authorization, step therapy, that are the banes of commercial insurance, are uniquely in Medicare Advantage and not, except for a handful, in traditional Medicare. Of course, in Medicare Advantage, they rely on smaller networks, as I was describing. They don't want you if you're terribly sick, and they want you if you're healthy, which is the opposite of how healthcare systems should work. We'll show you a little bit about their profits and their overhead, and we'll unpack a little bit more about the astonishing levels of fraud that I think you can fairly say are being attracted to Medicare Advantage. So, as Gordy alluded to, we've seen this system grow by leaps and bounds ever since its inception to now, depending on how you do the arithmetic. Roughly 50% of people in Medicare are actually in Medicare Advantage, to the point, and this is really an important thing, because Congress sees this growth and sees that as proof that people like it. Congress sees this growth and just last year and many other years wrote this letter. The overwhelming majority of people in Congress said people like it, and that's consistent. They're satisfied and they're happy with this. And they may as well have said, they didn't, but they may as well have said, stop complaining about Medicare Advantage. The market has spoken, and it's growing because it's better and seniors love it. That's how, frankly, most people in Congress think about the growth in Medicare Advantage. Well, there's somebody on the call who thinks a little bit differently than that. Hi, Don. Nice to have you in the room. I didn't know if you know I was going to actually quote you, but Don said this, I think, in the best way I've ever heard. He said, well, if an ice cream, I'm just going to read this, if an ice cream firm can offer ice cream for free because of a subsidy, well, then its market share will, of course, grow against firms that charge for that ice cream. The cause is not better ice cream, it's free ice cream. So, I think this is a really important metaphor to use with Congress when you're trying to explain that the growth is not that does not reflect what they like to think it does. So we showed you the overhead for traditional Medicare parts A and B. To be clear, traditional Medicare is synonymous with the word original Medicare, which is synonymous with Medicare Part A and B. Those are synonyms. I tend to use the word traditional, but there's that. And the commercial insurance companies, you can't just look at their overhead, you've got to add in profits as well. And they average, let's say, 15% according to SEC filings. Any of my charts with numbers, there'll be a footnote down at the bottom that you can kind of squint or get your face up to the camera and see. But they're all public filing type things. So roughly 15% overhead with really no solid research comparing clinical outcomes and certainly not showing them better to justify that process. Oh goodness, I did that twice. Sorry. Sorry about that. So I mentioned that Medicare Advantage plans have been accused of fraud, and it's important to notice that these are accusations by incredibly credible sources. So here's just the batch that have been accused of fraud by whistleblowers, another batch that have been accused of fraud by the U.S. government, and then overbilling by the U.S. Inspector General. So this is a rampant thing, and I submit to you that the design of the system, it's structured to attract and to attract this in Medicare Advantage. And I'd also have you notice that these are accusations. They're often settled for multi-millions of dollars, in or with penalties or massive fines, but they're seldom actually convictions. They seldom actually, the Medicare Advantage firms seldom take it all the way to the point of a trial with a conviction. And that's why we wind up seeing these ubiquitous, they settled for X millions of dollars with no admission of guilt. If they actually had an admission of guilt, it would be a lot more easy to exclude them from a federal program. So it's not surprising that there's no admissions of guilt. These overbillings, which I'm not going to unpack how they do it. I imagine some of you are quite familiar with that, but it amounts to a lot of money, many billions of dollars per year. Is that actually a lot of money? And does it pay off on savings? According to Kaiser, there have never been savings. There have never been demonstrated savings relative to traditional Medicare. And in fact, for Medicare Advantage, the opposite is true. And those billions of dollars are non-trivial. If you look at the dollar amount for other programs that are often on the cutting block for the federal budget, the amount of overbilling, just the overbilling, is larger than the entire NASA budget, depending on how the estimates are done. It's larger than the entire CHIP program. It's larger than the EPA or the prison system, federal prison system. It's a big chunk of money that doesn't seem to be getting very well addressed. So one of the things that they do in Medicare Advantage is that, Medicare has its guidelines of what's covered and what's not covered that are really incredibly well thought out and evidence-based. And Medicare Advantage companies are allowed to create their own proprietary coverage rules that, at least up to this point, are not publicly available. This study looked at the number of prior authorization requests that were denied by Medicare Advantage companies, but that actually met Medicare coverage rules. So 13% of the prior authorization requests that Medicare Advantage plans deny are actually things that, if you just look at Medicare's rules and don't look at the proprietary rules that you can't look at, would have been covered. And even higher number if you look at the number of denials of payment that Medicare Advantage companies deny the payment for, and yet those are things that Medicare would have said would have been paid. So they're allowed to use their own clinical criteria that are below and beneath, not above and beyond what Medicare coverage rules are. There's some hope that will change, but let's hope at this point. Recently, the Senate Finance Committee did quite an expose, as I think of it, about the deceptive marketing practices. This becomes very relevant to our patients. I got a letter similar to this, and you get these letters from Medicare Advantage companies. This is in the Senate Finance report, and they look like you're getting a letter from the U.S. government. In fine print somewhere it says not U.S. government, but they look just like they're a tax document that you darn well better pay attention to and sign your name, because who understands those anyway, usually? So, they do these marketing campaigns that are just, there's a whole raft of these in that Senate Finance report. And then here's something I thought was interesting about why these systems are growing. A friend of mine's an insurance broker, and I forgive him for that. And he got me wise to this, and it's actually now there's a study about data about this. The insurance agents get dramatically bigger commissions if you sign up for a Medicare Advantage plan than they do if you sign up for Medigap. And we know that roughly a third of seniors, when they're evaluating what way to go for their insurance strategy with Medicare, roughly a third of them rely on an insurance broker. So it's a real thing that they sound like they're on. They'll tell you that they offer all the products, and they don't. They offer usually a handful, a subset, but they try to present themselves as being neutral in this equation and just being your advocate, whereas actually they get pretty significant commissions for signing you up for Medicare Advantage, and the commissions for signing you up for Medigap are smaller and getting smaller. So the pressure on the incentives on insurance agents to get you to go into Medicare Advantage rather than Medigap is becoming more potent, not less potent. And the commissions to sign you up for a Part D plan are relatively small, and so you'll often find agents won't even talk to you about that. They'll just tell you what you could do for Part D. They often tell you just, here's the link to the website and go look at that, because that's actually pretty good. They could tell you the same thing for Medicare.gov for Medicare Advantage, but no, they want to steer you towards these plans. And these numbers, as impressive as they are only a part of it. They continue to receive a commission after that first year. After the first year, when they get the numbers I just showed you, they continue to receive annual commissions at about 50% of that level until, I think, about 10 years, until you either change plans or change brokers. So you'll probably get a phone call from them saying, hey, how are you? Because they want to stay in touch with you, so you don't go to another broker. But they keep getting these, so they are strongly motivated to get you to do this. So are they accurate? Well, Medicare recently did a secret shopper survey of calling insurance brokers to see what they tell them. And 80% of the phone calls, 80% of the secret shopper phone calls to an insurance agent about Medicare Advantage were inaccurate or insufficient. And my particular favorite is this one. Don't worry, the broker said, if your medication is not on the formulary, your doctor can just call the plan and the plan will add it for you. They're actually telling people this. They're actually telling people this, which is just, obscene. And as we know, the end result of this is that people have more cost-related problems if they go into Medicare Advantage than they do if they go into stay in traditional Medicare, with the caveat, which I'm going to expand more on in a moment, the caveat being that in traditional Medicare, there are, as you know, I'm sure, pretty significant copays and deductibles. And so if you're in traditional Medicare, you really do want to get a Medigap policy by hook or by crook, if you can. So comparing people in traditional Medicare versus people in Medicare Advantage, it turns out people in Medicare Advantage have much more problem accessing care because of financial barriers. And of course, no surprise, there's an even more dramatic difference based on race. So, the reason they sign up for Medicare Advantage is they think it's a better deal, and it's actually really not such a better deal. And these differences are even more striking in people that are in compromised health. As a result of all that, in the last year of life, people are more likely to leave Medicare Advantage and go back into traditional Medicare, because the sicker you are, the nearer the end of your life you are, the more these problems, networks and such, become troublesome. So the main reason they tell you that the people reported that they leave Medicare Advantage because they couldn't access the specialized care that they thought they could and should. Okay, so if it's so awful, there's these crummy ads that people are starting to learn about. It costs you more to be in it. Why are people signing up for it? Why it costs them money? Well, it's the key niche that's been created for them is that traditional Medicare, as we know, is imperfect. The 20% coinsurance without a limit, 20% coinsurance without an out-of-pocket limit for outpatient things, the hospital deductible, um, no limit on total out-of-pocket costs, and then you have to pay your premium for Part B. You want to get a drug benefit, you got to pay a premium for that. And I pay, I think, 45, $50 a month for that for myself. And then a Medigap plan, and I pay $200 a month for that. So I pay $250 with my wife. Then I pay $500 a month, and I have a Medigap and a drug benefit. I'm a retired physician. I can afford to pay that. But most folks, that's really real money, $500 a month. So there's three things they could do. They could do nothing. They could just go in traditional Medicare and do nothing, not get Medigap. But then their exposure to bankruptcy is substantive, and they need to be cautious about that. They could give up traditional Medicare and go into Medicare Advantage, or they could add Medigap to traditional Medicare. Maybe, maybe, and we're going to come back to that. But so let's compare, what is it like if you're in Medigap versus if you have Medicare Advantage? And I'm going to use the example of Plan G. There's a whole alphabet soup of Medigap plans, but these days Plan G is the one that almost everybody is selecting for a variety of reasons. So the premium for Plan G is averaging around $200 a month. But once you've done that, if you hit the $226 out-of-pocket maximum, then you're done with out-of-pocket expenses. The benefits don't change. Adding Medigap doesn't give you dental or hearing or vision or anything. You don't compromise at all on the network. You retain the entire traditional Medicare network. And then lastly, having Medicare supplemental and Medigap policy does not introduce new utilization management programs. They just don't do that. So I was making the decision, and we make it every year actually. And the average for Medicare Advantage these days, instead of buying a Medigap premium for 200 and a drug benefit for another 50, I could instead have spent $18 a month on average and gotten into Medicare Advantage and saved, more than $200 a month. And in many areas, you can actually join Medicare Advantage for free. I personally had free options for Medicare Advantage. So there's that. There is an out-of-pocket maximum, but it's ridiculously high for most folks. So there's an out-of-pocket maximum that sounds safer, but $12,000 out of pocket is enough to bankrupt many people. It offers additional benefits. Sometimes if you look at the list of things it offers, these are the things that in general attract the healthiest members, and not too many people that are end-stage COPD on home oxygen are very interested in a gym club. And I actually saw a report yesterday or today that showed that even though Medicare Advantage almost always includes dental as one of the benefits, it's really crummy dental. It's really crummy dental, not worth very much. And in fact, the people in Medicare Advantage tend not to get any more oral health care than do people in traditional Medicare, despite having so being able to say, hey, join Medicare Advantage and such, and you can get dental coverage. That's again an example of a very misleading bit of advertising. And they'll never emphasize to you that they direct you, that they often restrict you to only using their preferred folks. They never tell you about this step theory or prior authorizations. But the biggest thing on this list is that people are looking at retiring, and they're looking at $250 a month versus free, or $18 a month. I'm healthy. What do I care? The narrow networks and stuff. I'm going to be fine. If I'm sick, I'll deal with it then. If I run into these problems, I'll deal with it then. So the thinking of most people when they're 65 are looking at that arithmetic of 250 versus free, and they're saying, hey, I'll go with the free thing for right now. If I find that I don't like it, that they're doing things to me I don't like, I'll just switch and I'll go get a Medigap plan and be done with it. So I'll do it for a while, save some money for a few years. And what they don't know, the secret sauce they don't know, now in Massachusetts, it's a little bit different. You're one of the few states for whom there is some protection, but in most parts of the country, the protections that we rely on from the Affordable Care Act disappear in once you get into Medicare. So we assume, because we are used to that from the Affordable Care Act, we assume that we have a guaranteed issue. The Affordable Care Act says if you apply for a policy on the ACA marketplace, they have to write you a policy, and they have to write you the policy at the community rate. They can't underwrite you. They won't send you a health survey questionnaire and say, "Oh, you got the cancer. We're going to charge you 3 times as much." They can't do that on the marketplace plans, thanks to the Affordable Care Act. And people assume that's now the landscape of healthcare. And indeed, it is the landscape of the Medigap plans for the first 6 months that you're in Part B, or 12 months if you're going to Medicare Advantage. So if you go into Medicare Advantage, you have an extra few months. So if you're in Medicare Advantage for a year and you run into these problems and you decide, well, but I want to go there. Well, but I'm going to take vacation there, and I want a network that's broader than Massachusetts. You decide you actually realize the problems, and you decide you want more than what you're getting out of Medicare Advantage. You think, well, fine, I'm going to go get out of this, go back to Medicare, and get a Medigap policy. Well, not so fast, wise guy. You can't count on that. After you've been in Medicare Advantage for 12 months, or traditional Medicare Part for 6 months, if you didn't join a Medigap policy. After you've been in for 12 months, guaranteed issue of policy and community rating disappear. Guaranteed issue is only there for Medigap during the first 6 months on Part B. And after that, they can send you the health survey questionnaires and charge you more based on how sick you are. Community rating ends at the same time. And insurers can and do charge higher premiums or not sell you a policy if they decide that you're actually sick. So states have the ability to regulate this beyond what the federal government does, and 4 states actually include guaranteed issue for your life for Medigap policies, and Massachusetts is one. In Maine, they do it once a year where you can do it, but Massachusetts, along with Connecticut and New York, do have guaranteed issues. So hooray for you! But you probably have friends who don't live there, and a few more states than that have community rating, where they can't give you a specifically underwritten rate. So a few more states do that. But these protections that we've learned to rely on are not there when you get past 6 to 12 months in Medicare in most parts of the country. So despite all that, we're seeing a growing, not quite a tsunami, but certainly a wave, steady wave for the last 5 years now of people getting out of Medicare Advantage and going back to traditional Medicare. It was up to 17%, the most recent data that I've seen. And when you ask people why, well, it's all the reasons we've been harping on. Why do people leave Medicare Advantage? Well, they have trouble getting coverage for the drug that they thought they should get. They can't get the help they want from the MA plan. They can't even get information from the MA plan because they don't want you to have that. But the 2 biggest reasons that they leave, if they leave, are they are fed up with these narrow networks, and they are discovering that they have financial barriers to healthcare that wouldn't be there in traditional Medicare and with a Medigap policy. So they're discovering this, and they're unhappy about it. So how do you talk about this with folks? I put this all together in sort of 3 bundles. If I'm talking to patients about this decision, I tell them, you really have to understand this issue of narrow networks and financial barriers. You're 66 years old, you're still really healthy, you don't have anything wrong, but when you decide that you've got this and you want to go see that doctor, and there's somebody, and why would you want to pay somebody to tell you which doctors you can't go to? And that's what you're doing when you go into Medicare Advantage. You're letting them be paid to tell you who you can't go to, and that's you don't want to do that. You'd be aware that you're going to run into that. Be aware that the things you saw on the TV machine are often fraudulent. They're massive convictions, massive accusations, credible accusations of fraud and other misleading things, and understand that you might be trapped in an MA plan after a year. Physicians, that's good information, but I think that when we're talking with physicians, the main messages are: speak up. You're seeing these things. Raise your voice. Write the letter to the editor. Write the op-ed. Call into the radio show. Go visit with your congressional, folks. Raise your voice and talk about what only you can talk about. What your patients are going through. It's also good for docs to know that when they say, "Oh, I hate that Medicare," it's all these prior auths. They need to understand that they're talking about Medicare Advantage and not traditional Medicare. It's astonishing how often we sort of blur all that together in our minds, and it's important for docs to know that's something that's only happening in Medicare Advantage and really not uh, in any large way in traditional Medicare, and to know that single payer bills, and the one in the House and in the Senate, both explicitly ban step therapy and prior authorization and that kind of egregious stuff. And then the last thing I think physicians need to understand is that there are dozens of models that have modeled out the economics of Medicare for all, and not one of them, not one of them has a significant impact on overall physician income. And then on top of that, of course, your office operating expenses should be dramatically more manageable. For legislators, I think it's really important to go back to Don Berwick's comment about the free ice cream. That's the simple kind of explanation that makes sense to somebody like me. Ergo, it's the simple kind of explanation that makes sense to somebody in Congress. So this free ice cream model, I think, is really, really a good metaphor to use. It's not better ice cream, it's free ice cream. You also need to back that up with the evidence that I showed you that it's never generated any savings. Oh, we got to save money, the deficit. No, this is not a strategy to save the budget in the United States. And then it's astonishing how often people don't know anything about the accusations of fraud from multiple credible sources. So I promised you there'd be a call to action, and there is. So if you're not aware of this, you need to be aware of this. There's a deadline. Monday is the deadline to act up on this. So, I'm very passionate, as I know you all are being here at a PNHP meeting, very passionate about Medicare for all and single payer. And I think the odds that we're going to get single payer during the next 2 years, pretty small, pretty small. Not impossible, pretty close to impossible. On the other hand, the possibility that we could completely destroy traditional Medicare in the next 2 years or in the next 4 years by letting Medicare Advantage and similar attacks like ACO REACH completely take over Medicare, that's not theoretical. We're barreling down that road. So to me, if we want to keep traditional Medicare intact and thriving, we have to protect it. We have to rescue it. It's not very often that I've seen Medicare CMS make a really kind of stick their neck out and do a thing that would not do enough, but would do a lot to kind of reel back some of the misdeeds going on in Medicare Advantage. And, CMS puts out their proposed rules periodically, and there's one on the table now that's open for comment until Monday. And so the new comment would do a number of things beyond scope of tonight's discussion that would actually rein in some of the stuff that Medicare Advantage companies rely on. It would rein in some of the most egregious abuses. It doesn't go nearly far enough. We need to go a lot further. There's a whole bunch of other ideas we need to do, and it's not single payer, and it's not but oh my God, if we could sour the milk like this, if we could make Medicare Advantage less of a worthwhile Wall Street investment by souring the milk, doing some of these kinds of actions that CMS is proposing, well, hooray, hooray, we should attaboy CMS, pat him on the back, because I promise you, CMS is being deluged right now with lobbyists from the insurance industry explaining why these ideas are crazy and terrible, and they're gonna cause the Ukrainian war to implode. I mean, I don't know what they're telling them, but they're telling them all kinds of crazy stuff. And CMS needs to hear from us organizationally and individually that they should get the starch in their collars and do at least what they're talking about doing, and not cave in. So PNHP sent out an email to all of our members, I think, yesterday. I think it was yesterday, and it's got a lot more detail about the proposed rule. It's got a link to PNHP's comments that we submitted to Medicare. If you don't have it, you can go to PNHP's website and actually just look for the link for latest news, and then under latest research. So if you didn't get that email, let me or someone know, but you can go directly to the PNHP website and look for the latest news and then latest research, and you'll find it there. And you can, if you go there, you'll see the link for where you can comment. It's regulations.gov. Not very complicated. And then there's a docket number you can look up, and you can submit your comments, with your name, with your organization's name, or anonymously, depending on what you want to do. And the key thing is to do it to encourage CMS to resist the pressure that they're getting from industry. So Now is the time to do this. Literally, I had this slide before I put in the last slide. Now is literally, this week is literally the time to do it. There's also a bunch more information on this other website that PNHP set up called protectmedicare.net. So we'll look at that.